Dear Pure Urology Facebook viewers, good evening, one and all. Today is actually not the surgical technique topic. As you all know, the carcinoma prostate is becoming very popular even in India now because of its identification early by various methods. One of that is everybody writes MP-MRI before the biopsy is taken. Even in small towns, they are referring to the districts for the MP-MRI before we are doing the biopsy, because ultrasound guided sextant biopsy has become norm. Finger guided biopsy has gone. Not only that, there are various subsections in the discussion of biopsy, whether you wanted to do extra course in the doubtful areas, the saturation biopsy, repeat biopsy, all these are guided by the MP-MRI. In fact, we are entering into the era of fusion biopsy, where we combine both and then do the biopsy. So I thought it is high time I will cover this topic, interesting also in this, where normally when we see CT scan, most of the urologists are comfortable in reading the kidney, comfortable reading the bladder, comfortable reading in the tumor of the kidney, contrast enhancement, the stones, etc. When it comes to the MRI, if it is obviously fluid-filled space like cis, it's okay, but reading the prostate is little tricky. Sometimes T1, T2 weighted images and very perfect capsule is there with a large transitional enlargement of the BPH like that is there, then we can easily read. Otherwise, sometimes it looks hazy, we cannot identify. So I thought I have taken help of Dr. Pankaj Maheshwari sir. He recommended Dr. Sharad Maheshwari sir, who is a well-known radiologist in Kokilaben Hospital in Mumbai. So thank you, sir, for joining, Sharad sir.
Thank you so much for inviting me.
Before we go on to the talk, I like to ask you a few questions about your personal career, and then we will go on to live. If you don't mind, when did you start your radiology training and where?
Yeah, so in 1994, I joined radiology residency, and that was in Indore.
Where, sir? Which college? Okay.
Mahatma Gandhi Memorial College in Indore.
Yeah.
So there's a Hamidia hospital. The hospital is attached to it, MY Hospital.
Is that time MRI available in your training?
No, there was no CT or MRI,
No CT, MRI.
but we used to go out to have a little training on CT.
Yes,
so,
sir.
MRI, we did not have any exposure.
Then after your residency, then where did you move?
Yeah. So after my residency, I came to Mumbai and I joined Jaslok Hospital.
Very good, sir.
And Jaslok Hospital, I was there for 4 years. And almost 3 years I was working in MRI, and we had full experience, neuro, prostate. So I've been doing prostates in 1998, 99.
Okay.
And we used to do prostate.
When did you move to Kokilaben, sir?
And after Jaslok, I was in US and Canada for 5 years.
Okay.
I did my fellowship in abdominal imaging from Toronto.
Okay.
And then I was working for 4 years in Montreal, McGill University.
Okay.
And 2008, I returned back to India and I joined Kokilaben Hospital.
Great.
So I'm there since inception.
Yeah. So did you develop interest in abdominal imaging after the Montreal and Toronto training, or you will do all the body now also?
No. Right. Since 2002, I am exclusively doing abdominal imaging only.
Yeah, because in urology, subsections are forming now. And like in radiology also, a lot of people are confining to certain areas and not all the areas. So you are specializing in abdominal imaging?
Abdominal imaging. And we have such great urologists working with us. So automatically we are doing a lot of uroradiology also.
Yeah.
Dr. Yuvraja, Dr. Sanjay Pandey.
Yes, sir. They are the well-known and yeah. Now, voice. Sir, now with this introduction, I will request you to start the session. take your own time. Let it be little fundamental so that we will understand better. There is no
Right.
time limit, approximately 40 to 50 minutes we can take easily. Please, you can share your screen, sir.
Sure.
Yeah, I'm able to see your screen, sir.
Yeah. So I will switch my camera off.
Yeah, only thing is that your face is not seen once also here. Had it been seen, it might have been good.
Can you show the other camera?
No, sir. Now it is image is seen. What your image is seen.
Okay, fine.
We'll
No,
continue at the end. We'll switch over, sir. Please.
sure. Thank you.
Thank you, sir.
So, good evening, everyone, and thank you, Dr. Chandra Mohan, for giving me this opportunity. So today I'm going to talk on prostate MR, and we'll go from very basic stuff. So it's high time. Whenever I give my talks in radiology, I always tell them, think like a urologist before reading the scan. So maybe for today, you can think like a radiologist, and we'll move ahead from now. So you have been using MRI prostate at multiple time points as the patient comes to you for detection, surveillance, staging, treatment planning, monitoring the treatment. So MRI is now with you at all the stages as the patient comes to you. But there are certain problems because MR is a little complex and you have multiple sequences and each sequence appears different. Whereas CT scan, it's one plane and contrast, and most of the people, clinicians are used to CT scan images. But there is a problem when it comes to MRI, and that is because of the lack of technical knowledge. You are stuck in the jargon of T1, T2, diffusion, contrast, which becomes overwhelming, and there is a learning curve also. So let me go to the basics. I will not go into the physics, but let's do it in a fun way. So 1 is bad and 2 is good. That's how we'll start. Black is 1 and white is 2. Now, when you see your MRI scan, most of the times you will be having films. So what you do, you look at the bladder. So if you see the urine in the bladder is dark, then it is a T1 sequence. And if the urine in the bladder is bright, that is a T2 sequence. So this is where the money is. You can keep the T1 sequence on your side and just look at the T2 sequence. So before going to the MR image, in radiology, we take zonal anatomy of the prostate as 5 zones. So you have periurethral glands around the urethra, which we don't see. Then you have a transition zone, the central zone, which is around the ejaculatory ducts. And then the major part of the gland is the peripheral zone, and the anteriorly is the anterior fibromuscular stroma. So let's start with a skeletal framework. I'm going very basic because there will be some radiology students.
We want like this only.
Yeah. So let's go into the skeletal framework. That's a seminal vesicle, ejaculatory ducts, and that is the urethra. So periurethral glands, unless they are really enlarged, we don't see them. So we'll start with the transition zone, which is actually very small to start with. And it kind of half encircles the urethra. So this is the transition zone. Now, the transition zone is both glandular and stromal tissue. And when it hypertrophies, it enlarges and compresses the peripheral zone. Now we come to the next point. There is part of the tissue which encircles the ejaculatory ducts, and it is posterior to the urethra and the transition zone. So that is called as the central zone. Central zone is not so easy to see. It is quite small most of the times. So you can see those are the ejaculatory ducts, and the tissue around it is the central zone. And again, if I show on a sagittal image, that's the urethra. Those are the ejaculatory ducts, and the area here is the central zone. So normal prostata central zone is very like very low volume. You hardly see it.
Okay.
Just regarding the like the orientation. So basically there are three planes. One is a sagittal plane, which is cutting anterior-posterior. Then you have the coronal plane, which is left to right. And then you have an axial plane.
Yes, sir. Correct.
Okay. So
go to the previous slide, sir. That means it is most posterior around the entry of the seminal vesicle
ejaculatory ducts, right? Exactly.
Into the prostate.
Yeah. So as the ejaculatory ducts are going into the prostate gland, the tissue surrounding is the ejaculatory ducts. But
Yes.
most of the patients which you are seeing, they are elderly and there is some hypertrophy. So it is not so difficult in the patients who are actually symptomatic.
Yeah.
Okay. So just we'll recap skeletal framework, transition zone around the urethra, central zone around the ejaculatory ducts. So these two zones together are also called as the central gland.
Yeah.
Okay. So now the transition zone is small, but it hypertrophies, compresses all the tissues, and then it looks like this.
Yes.
Okay. One point I would like to say here, in radiology textbooks, there is no mention of median lobe.
Yeah.
So there used to be a lot of confusion, but now I realized that the posterior urethral glands or the transition zone, when it hypertrophies, it kind of jets into the bladder. So anything which is jetting upwards and compressing the bladder neck is called as the median lobe. But in theory, in the zonal anatomy which we read, there is nothing like median lobe, but anything which is compressing the bladder neck, which automatically called as the median lobe.
Okay.
And sometimes this also acts like a valve.
Yeah.
Okay. So now the fourth zone, which is the bigger zone, it is like a orange rind, like covering the rest of the zones. So like the 60 to 70% of the prostate gland is all peripheral zone. I call it as a mother zone because it covers everything. And the peripheral zone is primarily glandular. So there is fluid in the cells.
Okay.
There is not any fibrous tissue there.
Okay.
And the anteriormost zone is the anterior fibromuscular stroma, where it is just smooth muscles. There is no gland.
Okay.
So we move on the next image. Now, I also sometimes write prostate capsule, but there is no true capsule for a prostate. These are just fibromuscular extensions from the detrusor muscle. So it's more of a misnomer. You can call it as prostatic margin. So extra-prostatic extension. That's how ideally you're supposed to write, but it's okay if you write extracapsular spread. And then you have at 5 o'clock and 7 o'clock, you have these neurovascular bundles coursing along. So here you can see a nice prostatic margin, and this bright thing is all fat, and these dark things are the nerves and the vessels. So you can see a clear plane with the prostate gland.
Okay.
Yeah, but believe me, when patients are symptomatic and they have a disease process, it may not be cancer. such things become little difficult.
Yes.
Now, as per PIRADS 2.1, the one which we are following, the scoring system, the prostate is divided into 41 sectors. So that becomes quite overwhelming. So for practical reasons, while I'm making a report, I don't localize my lesion in a specific sector because this is very time consuming and you may not always find it practical. So what I do, I divide my prostate into base, mid and apex, and then anterior, posterior, left, right. So, but you can have a like a printout like this and draw where exactly the lesion is on the MRI. That may be a helpful thing.
Okay.
So this is like locating a lesion is very important. You can have your sectorial diagram with you. Now, if you see, this is the transition zone, this is the fibromuscular stroma, and this is the peripheral zone. Now, when you see a well-defined lesion like this, it's very important to know its exact location. Because if you have a well-defined lesion in the transition zone, it is benign. But if you have it in the prostate peripheral zone, then it is malignant. So with the help of this diagram, I can locate that this lesion is in the peripheral zone, and I call it as positive scan. And on biopsy, this was a ISUP2 cancer.
Okay.
So locating is an important thing. So now we're talking about what is good. So as I said, 2 is good. So T2 is good, and it is the primary sequence you should see first.
Okay.
And you know, when you are in periphery, liquids are good, you brighten up. So this is a peripheral zone. It is bright on the T2 aided image, and you identify T2 image by looking at the urinary bladder.
Yeah, bladder.
If the urine is bright, then you are looking at the T2 sequence.
Yes.
Now here is a spoiler. So you have a peripheral zone which is bright, but then you have a patch here which is dark.
Yeah.
So this is the party spoiler, and this is how a cancer will probably look like.
Okay.
This is a peripheral zone which is like everywhere there is a dark signal, but it is not so dark, it is mild, and you can have such an appearance with prostatitis. Or sometimes
this is not normal. Go to the previous slide. This is normal.
This is normal, and this in this bright dark patch, this is abnormal.
Abnormal. Now, when next slide, why it is so dark in T2 image?
Yeah. So in the next slide, if you notice, this is very dark. Here it is not that dark, but it is everywhere.
Okay.
So cancers are usually focal.
Yeah.
Peripheral zone. They are not diffuse like this.
Okay. It's uniform here.
Yeah. So this is like a prostatitis.
Okay.
But if the same thing becomes too dark and it is almost like a mass-like presentation, like here you can see a difference.
Yeah.
The margins and everything are intact. You can still make out various zones, but here it's more like a mass-like presentation.
Yeah.
So this is also diffuse, but here it is quite ugly, very dark, mass-like. So usually advanced cancers will look like this. Okay, so just to show you, this is a normal peripheral zone. This is a normal peripheral zone with a small cancer. This is like mild diffuse change everywhere. That's prostatitis. And this is like a more advanced malignancy where it is involving all the zones. So this you don't see so often currently because of the awareness and the patients going to the doctor early. This I'm talking of metro and the larger cities.
Yeah.
Now let's come to the transition zone. That is the center of the gland, and I'm calling it as core here. So peripheral zone and the transition zone. Transition is the core. So compared to the peripheral zone, transition zone is very heterogeneous. You can't, you don't have a homogeneity like this.
Yeah.
And it has a mixed signal. There will be dark patches, there will be bright areas.
Okay.
Now, when in the transition zone, when you have well-defined nodules, which have a capsular margin,
Yeah.
those are benign nodules.
Yes, clearly seen.
That is not cancer.
Yeah.
Now, like you had prostatitis, I showed you in the peripheral zone.
Medium dark, uniform.
Similarly, here, the transition zone is enlarged, but it has an element of prostatitis. Right now, just look at the scan, and later on, when I will show you cancer in the transition zone, you will realize the difference. So the difference is here, it is little, not very dark, more of homogeneity is coming up. And you have to see other sequences also, like the diffusion, contrast, and then make a final decision. But for a quick recap, this is how prostatitis could look.
Okay.
Now, how does a cancer look in the transition zone? Okay, so in the peripheral zone, the cancers were well defined and they were focal.
Okay.
And dark. And
Okay.
in the transition zone, the cancer is also dark, but here it is blurry.
Okay.
So the transition zone cancers you identify is their dark, which in MR language we call it as hypointense.
Okay.
Moderate to deep hypointense, where you can't define them.
Okay.
Then they are likely to be cancers.
Usually it is not common to see this much amount of cancers in transitional zone.
Yeah, you don't see so often, and there are so many variations, and it always takes you by surprise that you did not think, but there was a cancer.
Okay.
But the idea of MR is not to miss significant cancers.
Okay. Okay.
So if I say this prostate is more benign looking, it is okay, but I should not miss a properly seen cancer.
No. Okay.
Because you can have low-grade cancers which may not manifest the ideal appearance. Okay?
Okay, sir.
Yeah. So to recap, peripheral zone, it is bright, the cancer is dark, and it is focal, little bit well-defined. Transition zone is heterogeneous.
Yeah.
And the cancers are blurry and dark.
Yeah, hypointense.
Yeah. We move to the next slide. Now you will ask me, then why are you doing T1 weighted imaging at all?
Okay.
So the T1 weighted imaging is primarily done to look for hemorrhage. Okay.
Okay, sir.
So hemorrhage usually you get in a setting of biopsy.
Okay.
So patient had a biopsy and then comes for MRI and there is hemorrhage.
Yeah, yeah.
Now, earlier we used to say if somebody had a biopsy, the MRI should not be done for 4 to 6 weeks.
Okay.
But imagine you do a biopsy, it is suspicious for cancer, and you delay the MRI for 4 to 6 weeks.
It's late.
So it is not that anymore. By 2 weeks, you can do the scan. And I will tell you what the good news is.
Yes, sir.
The normal prostate gland or the benign hypertrophy, it contains a lot of citrate.
Okay.
So the normal tissue is more likely to bleed than the tumor.
Yeah, yeah. Yeah.
So there is something which we called as the hemorrhage exclusion sign. So this patient, you see there is a lot of hemorrhage.
Okay.
And this part, there is no hemorrhage, and this was the tumor.
So it is actually normal transition zone. There is a white.
No, this is a transition zone, which is okay.
Okay.
This is a peripheral zone.
Yeah.
And this area is all hemorrhage.
Yes.
While this is the tumor,
Where there is no.
there is no hemorrhage.
Okay.
So don't fear. You can still do the MRI. You give a gap of 2 weeks and then do it.
But for practical purposes, now people say that better to do MP-MRI before biopsy for all practical purposes.
Yeah, that's true.
Yes.
But it depends where the patient is, what are the availability. So it is very rare. Now in my setting, we are not getting any patients.
Even we are not doing biopsy without MP-MRI.
Yeah. But suppose a patient comes to you who is already diagnosed and there is hemorrhage, not to be bothered, because I can still stage this cancer.
Yes.
Like here you can see there is a capsular breach.
Yes.
Okay. So, well, this is just the introduction. The plot thickens from here. Let's make it more confusing now.
Yeah.
Rather, I'll try to make it easy.
Okay. No problem.
Okay. So we come to a second important sequence, which is called as a diffusion weighted imaging. Now, this is an image I've taken from a YouTube channel, Simply Rad. So they talk about what is diffusion weighted imaging. Those who are interested, they can go to Simply Rad and search for the diffusion imaging. So you have water molecules which are in a random motion in a normal tissue, and so they are able to move around like. So this is called as normal diffusion. While when there are cancers, you have a lot of cells. So which kind of restricts the mobility of water?
Okay.
So that is called as a restricted diffusion.
Okay.
So in MRI, there are 3 situations where you get restricted diffusion. One is malignancy. Because this is hypercellular and there is not much space to water to diffuse.
Okay.
Second is when there is a brain infarct.
Oh.
The brain cells die.
Okay.
You get a restricted diffusion. And third is in abscess.
Okay.
So prostatic abscesses will have restricted diffusion and cancers will have restricted diffusion. Now, prostatic abscesses are easy to diagnose. You will, as a radiologist, you won't confuse abscess with the tumor.
Yeah.
Okay. But those abscesses are not so common to see on MR.
So primarily diffusion imaging means it is a diffusion of the water in and out of the cells, which is restricted by tumor.
Exactly.
That is simple.
Very simple.
The water movement restricted by the tumor.
Yeah. But the problem is the diffusion images you get is a set of 2 images. You can think like this. We used to have a film camera. So the film we had was a negative. And then it was developed and then it is a picture. Right?
Understood.
Yeah. So we have a set of image which is called as a diffusion weighted image. And then we have a set of image which is called as ADC image. Okay. So if something is bright on the set 1, that is a diffusion image. And then it shows a signal drop, means the bright thing becomes dark. Then it is called as restricted diffusion. So that is the ADC image. So
with normal eyes, it may be bright, but with special movement image, it is becoming lost its brightness because of the movement.
Exactly. So the eclipse happens. It is like the eclipse happened. The sun is no longer bright. Okay. So let me show you the same case. You have a well-defined lesion here in the peripheral zone, which is quite well-defined. And it is in the periphery. So it is very likely to be cancer. But how do I confirm? I confirm it on my set of diffusion weighted images. So this is my first set of image, which is the diffusion image. and it is bright.
Okay.
So that corresponds to that lesion.
Yeah.
So now this is free diffusion, this is restricted diffusion.
Yes.
And now I go to the second set of image, which is called as the ADC image,
Where you are restricting.
and where this is restricting.
Mm.
So then we call this, we like with full confidence say this is a cancer.
Okay.
So you can actually measure this and give a value. Like on CT scan, we give Hounsfield units.
Okay.
Like you have a stone and we say the Hounsfield value is 900 or 400.
Yeah.
900 is a harder stone.
Yes.
So similarly, we can give a ADC value of this lesion.
Yes.
And a lot of studies have shown inverse relationship between the Gleason score and the ADC value.
Okay.
So lower the ADC value, higher is the degree of malignancy.
Okay. Okay. Whatever may be the value is inversely relation to the grade of the tumor.
Gleason score. One second.
Gleason score.
So when I see a clear-cut lesion in the peripheral zone, which is round, which is bright, and which is restricting, I know that this is a significant cancer, and very likely this will turn as 3+4 minimum, ISUP2.
Okay.
Now, what is dynamic contrast imaging?
So
Now,
in the previous discussion, we are not given contrast. It is only image differentiation where you have restricted image and you have interpreted that at ADC in mode.
Yeah.
Contrast is not given. Simple, plain.
Yeah, normally we are not giving the values.
Okay.
Okay. So now let's look at the at the molecular level, what is happening when you give IV contrast?
Okay.
Okay. So the contrast goes into the vessels.
Okay.
And through the vessels, it leaks.
Mm-hmm.
Now, as you know, in cancers, the capillaries and those are not like normal and they are more leaky.
Mm.
So they leak out, and what we see is called as enhancement. Okay. So like you are seeing this star in the night. So look at another case. So that is a transition zone. This is the peripheral zone. This is the tumor here. Yeah. And when I give contrast, I do multiple scans. So even before the other areas enhance, my cancer picks up the contrast. Okay. So, okay. Now, what is the role of contrast? In the peripheral zone, if the diffusion is positive, you don't need contrast. Yeah. Only when the diffusion is doubtful, then you want to do a contrast. But for practical reasons, it is not possible continuously monitoring every patient. And there you are giving like 15-20 seconds and then taking a call and you say, no, I don't want a contrast. And then when you sit in the later in the day, look in detail and you want a contrast, so then you have to call the patient again. So for practical purposes, better to give. We are giving contrast to every patient. Yeah, and take the images and read later on. Read later on. But it is perfectly fine that I want to monitor and then take a call to give or not. Then it's okay. Fine. Okay. Now one more thing. Generally, if you wanted to do me where financial constraints are not there, time constraints are not there, for practical purposes, better to undergo for prostate, especially for malignancy. Whatever study we do with contrast is better. Better, yeah. Unless the attending or the radiologist himself is there monitoring. So there are situations where patients are not affording or we are doubtful about the renal status. then I would myself go see the scan, take my time, and then say, okay, contrast not required.
Yeah, this MRI, sorry to ask a basic question, MRI related contrast is less toxic gadolinium contrast than what is we give in CT, isn't it, sir?
So gadolinium we give in a very small amount.
Okay.
So in that small amount, it causes no renal harm.
Yeah.
Okay.
Yeah.
Now, I am in last 25 years, I have never seen a case like that, but Americans have seen where the gadolinium deposits in the skin and gives very life-threatening disease. But it is, I have not seen, and many of my colleagues have never seen it.
Fine. Nice. Good.
So it also depends how many times you are giving that contrast. So there may be patients who may be getting 10 times for various reasons, then they have deposition and the body is reacting. But still, we take the precaution. If the creatinine clearance is below 30,
okay,
then we don't give contrast.
Okay.
Yeah. So, so when we come to the, why do you call prostate imaging as multi-parametric?
Yeah.
Now, all MRI scans are multi-parametric to start with.
Okay.
So whether you're doing neuro, MSK, everybody is doing T1, T2, diffusion, contrast.
Yeah.
But what happened when the prostate MRI started initially? They were doing only T1 and T2.
Yes.
Though the brain MRIs, they used to do everything, diffusion, everything. So later on, when they realized diffusion has a role in body imaging also, so then they started calling it as multi-parametric.
Yeah.
Yeah. So the multi-parametric MR, the beauty is it tells you the anatomy and it tells you the biology, the functional aspect. So morphology is by the T2 and T1 weighted images, while
discussed.
the functional assessment is done by diffusion.
Yeah.
Diffusion looks at the water motion, and that water motion is at the cellular level.
Yeah.
Then you have MR spectroscopy, which gives you the metabolic information. So currently we are not doing MR spectroscopy, but
Okay.
on MR spectroscopy, we try to look at choline and the citrate. So benign prostate has more citrate, while tumors have more choline.
Cool.
Okay. And third is the perfusion study, the dynamic contrast, where you look at the leakage of contrast.
Okay.
Now let me tell you here, the contrast has no role in the transition zone.
Okay.
Why is it so? Because of the morphology, there is a lot of fibrous tissue also there. Stroma is also there in the transition zone, and they take up contrast more. So by contrast, you cannot identify cancer in transition zone. So contrast has role only in the peripheral zone.
Great.
Okay. Yeah. So we'll move to the next slide. So this is a classical scenario where you're suspicious for cancer. You do a MRI. If you are able to see the MR lesion, then you have biopsy, the regular biopsy plus a targeted biopsy. If the MRI is negative and you still have a high chance of cancer, then you still go for the biopsy. And if it is a negative MRI, low clinical risk, you do nothing. So we have PI-RADS 1, 2, 3, 4, 5. 4 and 5 are cancers, but 5% of PI-RADS 1 can also have cancers.
Okay.
But majority of time, if I am not able to detect cancer on a MRI, then it is more likely not a significant cancer.
Yeah.
So trus biopsy has a problem. The tissue resolution, you may not always pick up cancers. So the ideal is to have a MR fusion guided biopsy. Now, if somebody doesn't have the fusion machine, they can have a look at the MRI first and then do the trus biopsy.
Yes.
And when you do an ultrasound biopsy after keeping the MR thing either in front of you or in fusion, 30% more chances of detecting a higher grade cancers.
Yeah.
Now, how many cores? Normally, a small prostate, 12 cores are enough.
Mm.
But there are certain situations when the prostate gland is big, or on MRI, if you see a peripheral lesion in the far lateral zone.
Okay.
So it is very important, and quite often we have seen tumors in the periphery. So unless you specifically target the far lateral region,
Okay.
then there is a chance you will miss the cancer.
Mm.
It is one of the reasons for missing cancers. One is the anterior most lesions.
Yeah, yeah.
If you do without MRI, you can miss those anterior lesion and these far lateral regions.
Mm.
So if you're not doing an MRI before biopsy, then make sure you take biopsies from the far lateral zone.
Mm.
So this here the prostate gland is not actually big. The volume was like 21 cc. PSA is 5, PSA density 0.27. This lesion corresponds with restricted diffusion here. And on biopsy, this was a cancer.
Mm.
Now coming to the patient preparation, there is no bowel preparation required.
Yes.
You can ask the patient to evacuate prior to the procedure and empty the bladder.
Yeah.
So if they can pass the stool and empty the bladder and then come to the MRI suite. So unless there is a history of urinary retention, we usually give anti-peristaltic agent, IV Buscopan.
Yes.
And the reason is the small bowel loops in the pelvis, they are always in peristalsis. So they cause a lot of artifact.
Mm-hmm.
And that can make, when there are subtle things, you're looking at the capsular breach or the seminal vesicle involvement, and you have artifacts coming from the small bowel, then it can limit your reporting.
Yeah.
So majority of times we give Buscopan, and only in 1 in 100 or 1 in 200 patients we had to catheterize them because of post-Buscopan retention. So the screening is important. And for a radiologist, it's very important to know what is the PSA, what is the historical PSA, what was the digital rectal examination, where was the hardness felt, is there any treatment given, any hormonal therapy, all that.
Yeah, great.
Okay. So we have two types of MRI. One is the 1.5 Tesla MRI and the other is a 3 Tesla MRI.
Mm.
So in the US, if they're doing a 1.5 Tesla MR, they use a prostate rectal coil.
Okay.
And some places use even for 3 Tesla, but for all practical purposes, if you're using a 3 Tesla MR, you don't need a transrectal probe.
Okay.
Okay. And at 1.5 Tesla also, if you go for a probe, it is very expensive.
Mm-hmm.
As such, the cost is high. So in India, it is okay to do either a 1.5 or 3 Tesla without any transrectal probe. Little bit tweaking is required on a 1.5 Tesla to make it a better quality, so the radiologist can interact with their application specialist.
Okay.
So key is the FOV, the field of view when you're doing the scan should be small.
Mm-hmm.
So mainly targeting the prostate region.
Mm.
Now, when we look at the PSA indices, PSA density is important for us. So the PSA divided by the volume of the prostate, if the PSA density is more than 0.15,
okay,
for the borderline cases, it is better to do a biopsy. But if the PSA density is more than 0.2, then there is more likely to be a cancer based on your abnormal MRI finding.
okay,
So we look at this. I see a lesion. I am not sure, doubtful. I will look at the PSA density. If it is higher, then I'm more likely to err on the tumor
Positive.
side.
Tumor side.
Yeah. Just an example here. So this is a large prostate gland which has volume of 63 cc. PSA is 6 plus, but the PSA density is 0.1. And this was benign on biopsy. Here you have a prostate which is 32 cc, but the PSA is 31. PSA density is 1. And this was a high grade cancer.
Yeah.
So these are classical examples. What I mean to say is, if you are in doubt, PSA density helps. Okay. Now, what is prostate imaging reporting and data system, also called as PIRADS? PIRADS is not staging. PIRADS is only for predicting the likelihood of detecting a cancer. So if I get a patient who has a prostate cancer already diagnosed on a biopsy, patient has come for staging to me, I will not give a PIRADS score.
Yeah.
Their staging, but I have to tell staging. And urologists have endorsed it. That is why we are now regularly doing prostate MR.
Yeah.
Very often, Dr. Sanjay or Dr. Yuvraja, they call me and ask, they just ask me, what is the PIRADS score? I'll say PIRADS 4. So they will only tell me, send the patient for biopsy. So the normally what happens, patient usually come in the morning, they do the MRI. There is a tentative booking for the biopsy. Usually they get the biopsy in the same setting or the next day.
Yeah.
So the goals of PIRADS was to standardize the protocol of scanning, standardize the reporting, reduce the inter-observer variability. Most of our scans are first reported by the residents, our DNB students. And since we are using PIRADS score, there's a lot of very low inter-observer variability after a certain time of training. And as I said, it is very short and easy communication. You just call and say it is PIRADS 4, it will need a biopsy. But one thing, these are all guidelines. If somebody doesn't want to use PIRADS but still able to give you the right answers, it's okay.
Yeah.
Now, what is the assessment in PIRADS? Now, the assessment is based on 3 sequences: the T2 weighted sequence, the diffusion imaging, which is a set of 2 images, and the dynamic contrast imaging. Now, all the 3 sequences are utilized in the peripheral zone. For the transition zone, only T2 and diffusion are utilized.
Okay.
Okay. Now, there is a 5-point scale for the T2, 5-point scale for the diffusion, and 2-point scale for the contrast.
Okay.
So contrast is easy. No enhancement, enhancement.
Yes.
So 1, 2. For T2 we have 5, and for diffusion we have 5. Now, just to again reiterate, the cancers in the peripheral zone are dark and they are more focal. While the cancer in the transition zone are also more dark, but they are blurry.
Okay.
And homogeneous. So, our highest priority is differentiating a indolent versus significant cancer. So, chances of missing a significant cancer on MRI is less if done appropriately.
Okay.
Okay. So, based on the T2 score, diffusion score, and the contrast, we finally create a PIRADS score. 1 and 2 are benign. 3 is intermediate. 4 is high chance of a malignancy. 5 is a very high likely chance of malignancy. And X is unreportable. Now, unreportable, sometimes there is a hip prosthesis on both sides. There's so much artifacts you cannot see it. Or if the patient has not cooperated, or if there was too much of rectal gas which was interfering. But in such situations, you can replan.
Okay.
Okay, now we come to those 5 categories on a T2 weighted image. The easiest is one where the entire gland is, the peripheral zone is hyper intense, means it is bright or white.
Yeah.
Okay. So from 1, let's go to 5, which is also easy. So you have a large focal T2 hypointense, that is a dark lesion, which is more than 1.5 centimeter. That counts as score of 5.
Yes.
Okay. Only for the T2. We are talking only of T2.
Okay.
If you have a same lesion, but it is smaller than 1.5 centimeter, then it is called as 4.
Okay.
Okay. So 4 and 5 are same. It's just the size measurement.
Okay. Okay.
Now 2 is, you quite often find these linear, light, dark lines which are mildly hypointense. This is a very common finding, and these can be sequel to previous prostatitis. So that should not bother us. So that is become 2, and anything else you can put in 3. That's the intermediate category.
Can you repeat, sir, these 2 and 3?
Yeah. So 2 is linear wedge shape, mildly hypointense lines, which are very indistinct. That is usually sequel to previous prostatitis. Okay. And as you know, prostatitis may not be symptomatic always. Just inflammatory, patient may not know.
Okay. Okay.
While 4 and 5 are more focal lesions. So 3 is the intermediate category. When you cannot fit something in 1, 2, 4, 5, you put it in 3.
Yes. Okay.
Okay. Okay. So now step 1 is over, where you have evaluated the T2 weighted images. Now you go to the diffusion weighted images. Okay. Diffusion weighted images.
Yeah.
So this is little complex. I don't think I should cover this.
Okay.
We can simply focus on this 4 and 5.
Yeah.
You can see there is a bright lesion on the first set of images, which drops the signal on the second set of image. So this is called as a restricted diffusion. And
So
same thing is happening here.
Yes.
So this is 4 and this is 5.
Yeah.
Okay.
Again, here size a little bit.
Size, yeah, same.
Same concept, that restriction of the movement of the water. That way, initially it looks bright, later it looks hypointense more. That is more characteristic of cancer. If it is larger periphery, it is high grade. So-called PI-RADS score, it goes high.
PI-RADS 5, then PI-RADS 5. Yeah. So now, when you come to scoring in the peripheral zone, the diffusion has say over the T2.
Yeah. Oh.
If I see something on T2 which looks like category 3,
okay,
but on diffusion it is category 4.
So you go to 4.
Then it supersedes the T2
weighted image.
So T2 is the assistant and diffusion is the master.
Master. Okay. Right.
This is in the peripheral zone.
Okay.
Okay.
In the transitional zone, it is difficult even in diffusion.
Yeah, in the transition zone, it is different.
Stroma will be there.
Okay. Transition zone, it is different. Here, T2 is the boss.
Yeah.
Diffusion is the assistant.
Yes. Okay. Great. Great. Because water movement cannot be assessed so easily.
Because there is also fibrous tissue there. It's a totally different thing.
Yes.
But again, significant cancers will restrict even in the transition zone. But there are certain issues. So now let's go to the transition zone. Now that we have covered the peripheral zone, okay, contrast is easy. Whether there is
already told whether it is contrast leak is present or not present.
Yeah. So when T2 is also not sure, diffusion is also not sure in the peripheral zone, then you look at the contrast.
Yeah, yeah.
And then contrast will supersede all.
Yeah.
Okay. Yeah. So transition zone, this is like a normal transition zone, slightly enlarged, bit of heterogeneous. You don't see any nodules there. Now here, that is PIRADS 1. Now here is a enlarged transition zone which has multiple nodules.
Yes.
If you see, some of the nodules have full dark line around them, the capsule. These are the typical nodules and they come in category 1.
Okay.
If there are nodules which are not fully marginated, then they come in category 2, the atypical nodules.
Basically, irregularities. In this region, tumors are irregular.
Yeah, tumors are blurry.
Blurry.
Blurry, yeah. So this is PIRADS 1 and PIRADS 2. Now in the nodule also there are subcategories. I think I will skip for this lecture the talking of typical, atypical, different type of nodules. Let me skip that. We just remember this. If you see a well-defined nodule, it is benign. Okay. Now, how does a tumor look? Tumor look like a erased charcoal. So it is dark and it is blurry. So like this area is suspicious for a tumor compared to this area. Or sometimes they are lenticular shaped like this, or they have spiculated margins. So there's a transition zone. Now in transition zone, let's go to the category 4 and 5, which is easy.
Yeah.
I always tell my residents, don't get in the jargon of 3. 3 can be confusing. First, see you can pick up 4 or 5 or not. If you can't pick up 4 and 5, then you go into 3.
Yes.
So, and believe me, picking up a PIRADS 4 and 5 is easy, whether it is a transition zone or peripheral zone. So that is why I say the chances of missing a significant cancer are less. So here in the transition zone, we see a lesion which is dark and it doesn't have a margin, which you can define.
Yeah.
It is homogeneous. And see, the other side is heterogeneous. Some areas are bright, some areas are dark. And when this is 1.5 centimeter, it is PIRADS 5. When it is lower, it is PIRADS 4. Now 3 is the intermediate when you are not able to put it in 2 or 4. But then at this point, when I'm stuck at 3, I will look at the clinical aspects, the PSA velocity, free PSA, PSA density, and I'll take a call whether I want to upgrade it to 4 or keep it at 3.
So basically, a dark, irregular, large lesion in transition zone is not good.
Yeah, and they should be homogeneous.
Homogeneous.
Yeah, so if you just draw with a charcoal, you kind of smudge it.
Okay.
Diffusion has same criteria as the peripheral zone, but on transition zone, T2 is the boss.
Yeah, because it's difficult to restrict this. The image restricted is difficult.
No, here sometimes even non-tumorous areas show some restriction because of that's a different histology, morphology in that region.
Yes. Okay.
So diffusion becomes important in transition zone only if it has 5 points. If it is getting less than 5, then you don't bother about diffusion in transition zone.
Okay.
Okay. This is just how contrast. This is a different scan. You see a lesion here, which is the peripheral zone, and even before any other part of the peripheral zone, this tumor picks up the contrast. And that is the restricted diffusion you see.
Very beautiful.
Yeah.
Yeah.
Thank you. Now, I'll cover 2 areas, the transition zone and the AFMS, anterior fibromuscular stroma. So in the PIRADS 2, there was no talk about central zone and the AFMS. So as we said, AFMS, the central zone is around the ejaculatory ducts.
Ducts posteriorly.
Yeah. So here, if you see, the central zone is hypertrophied on both sides, and it is asymmetric also. Here it is more darker, bigger than here. So central zone itself doesn't get cancers, but almost always it is involved by the cancer in peripheral zone or the transition zone. So if you see, there is already some the cancer here in the peripheral zone, which is jetting up into the central zone.
Okay.
Okay. So isolated cancer is very difficult. It is rare in a central zone.
Yes, got the point.
Okay. And this is the tumor in the anterior fibromuscular stroma.
Rare.
Anterior fibromuscular stroma also doesn't get cancer on its own. It is always extension from the adjacent transition zone of the peripheral zone.
Okay.
But it is very important to see this because the lesion is very anterior and it is one of the cause of missed cancers.
Yeah.
Because the tumor was anterior and could not be biopsied.
Yeah.
Okay. So to summarize, diffusion weighted imaging dominates in the peripheral zone and T2 dominates in the transition zone.
Okay.
Now, the contrast plays a minor role in the peripheral zone.
Yeah.
And diffusion plays a minor role in the transition zone.
Fantastic.
So contrast is problem solving in peripheral zone. Diffusion is problem solving in the transition zone.
Okay.
Yeah. Okay. Now let's move to some cases.
Yes.
So this was a young, anxious gentleman, which they had a family history. So in metros, you get such kind of patient who they still want to do an MRI. So sometimes it is good to allay their anxiety. So you do an MRI, you see the normal peripheral zone, that is a normal transition zone, that is the diffusion, this is the ADC. I don't see any restricted diffusion. Contrast, there was no early enhancement in the peripheral zone. Normal MR, patient is also satisfied, anxiety is gone.
Perfect.
Now scenario 2, patient is symptomatic, PSA is high and never had biopsy. So randomized control trials support use of multi-parametric MRI in such situation. And 1/3 patients can avoid biopsy after doing the MRI. And if the MRI is not positive, there is less chance that you will do biopsy. And as I said, a normal prostate MRs can still have cancer, but usually it will be an insignificant cancer. So you are reducing the chance of picking up an insignificant cancer.
Yes.
Okay. So here is a patient, T2 weighted image, not something classical I am seeing. Okay. But on the diffusion, there are some bright areas, but not so much of restriction. If this bright, everything would have become dark,
then it's high suspicion.
Yeah, then I will override this T2 finding also. Because T2 is not dark, but this is not showing up restriction or diffusion. And when I give contrast,
no contrast.
And when I give contrast, this whole thing enhances at the same time.
Yeah.
There is no focality that one thing is enhancing early.
Yeah.
So I could confidently say that this is likely a prostatitis.
Yes. First time I am able to see even T2. I got confused after the diffusion weighted and contrast. I am feeling very clear. Right. With your whatever you taught now. Fine.
Yeah. So this was a prostatitis. I think biopsy was not done. Then I don't think patient came back also for the follow-up. Probably their symptoms resolved after the antibiotics.
Okay.
This was a little confusing. There was a young patient who was not tender, who had high PSA, and all the features were like cancer. Lot of dark signal, you're bright here, there is restricted diffusion. It is also enhancing early. So we call it as PIRADS 5. But the urologist felt that this is not a cancer. He had his all doubts on it. So they decided to observe, and antibiotics were given. That thing resolved. Okay. So prostatitis has everything which can excite you. It can look like a cancer because it can give kind of similar features at times. So you have to keep in mind, and so this is where you call the clinico-radiological correlation, because you are treating the patient, not the radiology image. Now this is an example of severe acute prostatitis, and if you remember in my start of the talk, I said abscesses can show restricted diffusion. So these are abscesses in the peripheral zone. But these are too bright for a cancer. So you see them very bright and they are very restricted. And you can see like non-enhancing fluid-like things. So this is clear-cut prostatitis.
So there should not be much confusion, because in T2 they are very, very bright. And in contrast, they will not uptake and tenderness will be there. And transrectal ultrasound, some fluid will be there. These are all very obvious points which favor the abscess. So you should not confuse at all.
But this MR tells you the severity. Sometimes you can have a case like this. It can really, you are lost what to say. So this patient eventually, after a lot of discussion, went for a biopsy. Because if I am not confident to say benign or not confident to say cancer, it is better to biopsy. There is no pride here.
Especially if the PSA is rising.
So my pride is not saying that I'm always right. So this was biopsied and this was chronic prostatitis. And this is a case of post-biopsy prostatitis. So you have these bit of bright, bit of dark areas. They're not very dark, how you see in a tumor. They show a lot of restricted diffusion also. And you contrast, you can see there are abscesses. Okay, so let's go to a scenario 3. Patient had a high PSA. There was a high clinical suspicion. For whatever reason, MR was not done and the biopsy was negative. So you have missed the occult tumor. Now, there is I read it in an article and I was also surprised that more the biopsies you do, there is a declining rate of cancer detection after each biopsy. So the second biopsy should be very well planned. And you should definitely do an MRI. There is okay, so you do a good quality prostate MRI. And as I showed you already these images, you have to look for such occult areas. And especially in my initial days, we would miss very low cancers like in the apical region. Because you may not go so low. So there are cancers. You have to be careful. And now we will look some cases. So here you have a prostate peripheral zone. You see this side, the volume is low. And it has little bit ill-defined dark areas which are mildly hypointense.
Yes.
Not as significant as cancer, not much of restricted diffusion. So this is probably a sequel to previous prostatitis, and some volume is also lost.
Okay.
So this we called as PIRADS 2. Probably this did not undergo a biopsy also.
Okay.
Okay. Now another patient where the volume is 30 cc, which is not big. PSA is almost 6. The PSA density is 0.19, which is a borderline thing. Above 0.2, we start thinking of cancers. So now here on the T2 weighted images, there are multiple T2 hypointense areas.
Yes.
Right? You can see.
Yeah.
Little bit of brightness, little bit of signal drop, but I'm not that impressed. So I go to the contrast. There is no enhancement.
No enhancement.
So, then you leave it as PIRADS 2 or a PIRADS 3.
So ultimately, boss is when you put little bit contrast uptake is also very important.
Yeah. So if the boss, that is the diffusion weighted image, is in a doubt, then you call the super boss, which is contrast.
Great.
Yeah. So we called it as PIRADS 3, and so it underwent biopsy also. And because the PSA density was also like 0.19, so we didn't want it to leave it as 1 or 2, and then it went to biopsy, and this was benign prostatic tissue. Okay. So 9 to 12 were all from the left side.
Great.
Okay. Another case. This is not a big dark area, but doesn't look so good. The capsular margin is little
disturbed,
irregular, right? How you see here. There was some bright signal and there was some restricted diffusion. Some areas were restricting more. Okay.
More posterior.
So I'm not comfortable calling it as 1 or 2, but PIRADS 3. So we now call the super boss. So based on the diffusion, we are calling it as PIRADS 3. We give contrast, and that area takes up the contrast before the other side.
Yeah.
So we upgrade it to 4.
Right.
And then we do a biopsy. It was a ISUP2.
Okay.
Yeah. Now, in a situation where you cannot give contrast, you can still manage, as we have seen so many cases. Okay. So now we have a prostate which is a volume of 27 cc, which is not big. And PSA is high, PSA density is 0.26. So even before looking at the MR, I know I'm going to pick up something. So look at the left side of the gland. You see a wedge shape, mildly hypointense region, which shows some bright signal.
Dropping
maybe some restricted, but not very classic type.
Not much.
Yeah. So, and there was no contrast. So I call it as PIRADS 2.
Yeah.
Okay. And on biopsy, this was benign prostate tissue. Okay. But there is something which is called as satisfaction of search.
Yeah.
Don't be satisfied with your one search, especially when the PSA density is high.
At least that area can be biopsied 1 or 2 pieces more also if you have doubt.
Yeah. So actually everything was biopsies together. So if you see here, it's a smaller lesion which is quite dark and very impressive signal and restriction.
Yes.
So this was a cancer on biopsy. So the cancer was on the right side, not on the left side.
Got the point.
So what was looking more to your eyes was actually benign.
Yeah. Okay.
And this also shows us that diffusion is the boss. T2 may not be great, but diffusion is important.
Compared to T2.
This is a clear-cut case. You have a hypointense lesion here, which is bright, which is showing a restricted diffusion, and it's showing early contrast enhancement.
5.
So this is a significant cancer, and 99% radiologist will not miss this.
Yeah.
So the job is done. So this is PIRADS 4, and this was a cancer patient, also had a PSMA PET. So you see, only there was one lesion which was very much corresponding to the diffusion.
Yeah.
So diffusion is also functional imaging, and a PET CT is also a functional imaging. But PSMA PET is definitely very specific for cancers.
Yes.
Another case, this is also PIRADS 4. Now, the point I want to make here, you can clearly see that there is the prostatic margin is broken, and normal fat is bright like this, and you see this all coming out. So if you have a PIRADS 4 case, and if you think the capsule breach is there, so you may not always call it as a capsular breach, but you upgrade it to the 5. And you can put a disclaimer also that the margin is not clear, it is very irregular. So that itself tells a urologist that I'm looking at a capsular breach.
Yeah.
This was a Gleason's 9 cancer.
Yes.
This is a clear-cut 5. No doubts here. Restricted diffusion and the T2.
Yeah.
Now this is a clear-cut case of extra-prostatic extension. Why? I will be very clear, and I will actually put on the report, because even the tumor tissue which has come out shows restricted diffusion. So now there are actually it is very difficult to call a prostatic extension, extra-prostatic extension, because not always you see classical things like this, but there are certain signs which make it suspicious. Like a long tumor contact, tumor capsule contact. If it is more than 1 centimeter, there are good chances of extracapsular spread, which may be microscopic, not seen on MR. A good capsular bulge or a irregular margin. So I know I was asking Dr. Yuvraja once. So he said, when you say a capsular bulge or a long tumor contact, then I would usually cut the nerves on that side.
Yeah.
And preserve on the other side.
Okay.
Now this is a case where the peripheral zone is nice, transition zone is heterogeneous. This area was non-circumscribed, suspicious for me. I would personally put it in PIRADS 3. Okay, but
for us it is very difficult. For our eyes, it is very difficult.
But the PSA was very high. PSA density was 0.37. So I knew, even if I say PIRADS 3 with this parameters, it's going to go for biopsy. So I called it as PIRADS 4. But if I go by books, I'll have to call it as PIRADS 3. So it is not something which is binding and you have to follow.
Yeah.
And the same patient, after the biopsy, had a PSMA PET. And there was a pickup in this point.
Okay.
This is just an example how a PIRADS 3 and PIRADS 5 would look on a transition zone. Right?
It's very obvious on the right side.
And if the diffusion is category 5, then it is considered a positive thing in transition zone also.
Yeah, okay.
So these 2 patients, these are ADC image of the 2 patients. Here, after the treatment, the PSA value dropped to 1.6. And here the patient, the velocity, if you see, from 2013 to 2021, the PSA is consistently rising.
Yeah.
So the PSA velocity is very important.
Okay.
So the one was prostatitis, other was a cancer.
Yes.
This is a little bit advanced, which is involving both the transition and the peripheral zone. that the PSMA shows the entire gland is hot. Okay. Then we come to the surveillance. Those who are at low risk for prostate CA or the Gleason score is low, and you don't want to operate, patient is elderly or the patient themselves don't want a surgery, then you can put them on a surveillance. So this is a MRI from 2016.
Yeah.
And the same patient then comes in 2019. PSA is almost hanging around the same thing, but this is becoming more smudgy and more restriction. And this was biopsied, and there was a cancer, ISUP2. But the patient had good 3 years monitoring.
PSA progression is not there.
Yeah, it was so probably it was a 6 year, became 7 over the time.
Okay.
Now, screening is not something practical for prostate, because to prevent one biopsy, you will have to do thousands of prostate MR. So, and it will not give any benefit in survival. So as of now, screening of prostate is not there. So to conclude, PSA burden is, the cancer burden is going to increase as the population is aging. It's a challenge. We need to be ready, and MRI plays a very important role. So it's very important for the radiologist to know the MR in detail, and it is equally important to interact with the urologist and learn from them.
Yeah.
So I think we can break here.
Yes, sir. Great. Fantastic.
Thank you, sir.
I must appreciate. Actually, I have less knowledge today. I listen very carefully like a LKG student, and I'm really happy. And this YouTube link will be there. I will re-announce in the Pure that it is very good talk. And even in future, if you take a class on renal tumors with CT contrast enhancement, it will be nice, because your interest is abdominal imaging. We will be very happy maybe after 6 months, sir.
Yeah, 100%. So because now we are able to actually, we are able to call whether it is papillary or a chromophobe or a clear cell.
So that topic will be interesting.
Yeah.
We will take up within 3 to 6 months. And the way you explained, exactly I wanted the same way. Exactly I wanted the same way.
Okay, sir.
Thank you. Thank you very much. Great. You look very young for your knowledge, and maintain the same. Thank you very much. Highly appreciate it.
Take care.
This link will be there forever.
Sure.
Today 140 audience have seen. By tomorrow it will be more than 500 to 1000.
Okay, fantastic.
It's like that they see in the night. That's